¿Empezamos? ¿Les parece?
Sí, perfecto.
We
Ok.
start. Is that a good idea?
Juliet, ¿podemos empezar?
Juliet, should we start? Can we start, Juliet?
Adelante.
Please,
Gracias.
yes. Thank you very much.
Muy buenos días
Good morning
a todos y todos.
to all.
Yo soy Roberto
I am
Lunes. Yo soy economista
Mr.
senior
Roberto
del Banco Mundial
Lunes
y
Yunes,
yo
and I
les
am
doy la
economist from the World Bank,
Luis
and I would like to welcome
muchas gracias por aceptar
and to thank everyone
nuestra invitación para
for
compartir esta
accepting
nueva
our
con nosotros.
invitation to be with us
Hoy
today.
tenemos el tercer
Today,
y
we
último
have the
webinar
third
del
and
nuevo
last
ciclo que
webinar
llamamos ciclo de atención
of the
en
cycle that we
Latinoamérica
call the cycle of care in Latin
experiencias
America,
de Colombia,
experiences
Perú
of
y Chile.
Colombia, Peru, and Chile.
En el primer webinar
In the first
tuvimos
webinar,
casi un mes,
that must have been
ese mes, el primer
a
mes de
month
septiembre,
ago, at the beginning of the September,
los líderes del proyecto IADA
the leaders
de la Universidad de
of the
Dartmouth,
project of Dartmouth University,
proyecto IADA prevención y
which was
diagnóstico de
prevention
depresión y uso
and
de sustancias de
diagnosis
alcohol
of
en Colombia,
depression and alcohol abuse in Colombia, presented
presentación
the results
proyecto
of that
en
project
municipios del país.
in 6 municipalities of the country.
Hace un par de semanas también
Some
tuvimos
weeks
la
ago,
presentación de una muy linda
we
experiencia
had the presentation of a beautiful
en los centros
experience
comunitarios de atención
in the
salud
community
mental
care
en
centers
Perú.
of
Vimos también
mental health in Peru. We also
han
saw the
tenido
impact
las decisiones de salud pública,
that the decisions on public health have had
el manejo de
on
los
those
recursos
associated with
basado en
budgets
resultados.
based on results.
Hoy nosotros
Today,
vamos a cerrar ese
we are
ciclo
going to
con
finish
una
this
salud
cycle,
mental
closing
con la
it
experiencia de Chile.
with the Chilean experience.
Psiquiatras e investigadores
Psychiatrists,
de salud mental
researchers
de
in mental health
Valparaíso
of the University of Valparaíso and the Católica University of
investigadores
Chile, as well as researchers from Peru and Canada,
discuten y analizan el
discussed
fortalecimiento
and
de la salud
analyzed
mental
the strengthening of mental health in the primary health care centers and that are tied with the mental health system and with the community in Chile. So once again, I would like to welcome all very kindly, but before starting with the presentations, I would like to remind you some logistical housekeeping issues. Firstly, please remember that we have simultaneous translation. There at the bottom bar, you have an icon for interpretation, and there you can find the language in which you wish to hear the presentation. The microphones are all deactivated, they're muted, and in that sense, we request of you to make your comments and questions on the chat that you have there at the bottom of the screen, so that we, at the end of the presentations, have an opportunity to have a healthy debate. I would also like to remind you this, that this session has been transmitted directly in Salud Derechos channel, and it will always also be recorded for academic purposes, and so that it may be queried in the website of Salud Derecho. Without further ado, I invite all our guest speakers, and I invite Rubén Alvarado Muñoz, who is a psychiatric doctor and magister in public health and PhD in psychiatry and community care. Dr. Rubén is a researcher in public health and mental health, and he is a professor of the Public Health of Medical School of the University of Valparaíso in Chile. And Dr. Alvarado will speak to us on implementing the component of mental health in Chile. Dr. Alvarado, welcome. 20 minutes for your presentation, please.
Listos para escucharlo. Muchísimas
And
gracias.
we're ready to hear you. Thank you very much.
Muchas
Right,
gracias,
perfectly.
Roberto.
Well, thank you very much, Roberto.
Muchas gracias a todos
And
los
thank you
que
very much to all of
acompañan.
you who are with us.
Un placer estar con
It is
Humberto,
a
que
pleasure
está
to be
compartiendo
with
con
Humberto
nosotros.
that I see here who was among our
Y
guest
un saludo
speakers,
también a todas
and
quienes nos están
a
escuchando.
greeting to all who are
Eh,
listening to us.
lo que yo voy a hacer hoy día, me
What
imagino que
I'm
están viendo
doing,
la
I
presentación.
imagine that you're seeing the presentation on the screen. Is that right? Yes.
Jaime,
Sí,
Fanny.
sí,
Sí,
Roberto.
señor.
Sí.
Perfecto.
Yes, yes, we can see it.
Entonces, y les voy a pedir también que me
So I'm
digan
going to
si
request to
avanza
tell
algo.
me if
Creo
it
que sí.
progresses well. Yes, it does well. Yes, it does progress
Perfecto.
well. Yes, perfect. Yeah.
Entonces, lo que voy a hacer es
So what I'm
fundamentalmente
going to do is
15
basically
minutos
in the
tratar de
15
contar
minutes, I'm going to
cuál
try
ha sido
to
la
tell
historia
you
de
what has
cómo
been the
en los
story
últimos 30 años,
of
desde
how
que
in the
Chile
past
volvió a la
3 decades,
democracia,
since
hemos
Chile came back
pasado
to democracy, we have
no
passed
tenía
from a model that did not have any
atención
component
primaria,
in mental health,
realmente
in
mínima,
primary health care,
incluía
which was very minimal
hacia
and very
otros,
few sites,
a un
to
sistema hoy día
a
que está en
system
red, en el
today
cual
that is integrated in a network
la atención primaria se
where
transforma
the
en
primary
continuidad
health
de
care
atención
becomes at the
de
first
una
level of care
cobertura que se
with a
extiende
coverage
a
that
prácticamente todo
extends
el país, todas las poblaciones
throughout
del
the
país.
country,
Y
and
cómo ha sido esta historia,
how
qué
this
factores fueron
history,
importantes,
what
quiénes fueron
factors were
importantes,
important, what
y tratar
landmarks were
de
important,
contarles
and to try to
las
tell
experiencias o los aprendizajes desde el punto de vista
about the
de
experiences or learning
decisiones
lessons learned
sobre qué cosas
in terms
ocurrieron
of policy as to what
efectivamente, qué cosas
were
fueron
useful and
relevantes
were
para la toma de
relevant
decisiones en ciertos momentos
in
del
the
proceso.
decision
Entonces,
making process at some given
eso es
point in
lo
time. So a bit of that is what we're
que
going to
quería
walk
para
through,
no ir retrasando
and
con esto.
I'm going to go ahead and
Esta
proceed
es
with this.
la
This
situación que
is
tenemos
the
actualmente hoy.
current
Si
status.
ustedes se fijan,
Today's
tenemos
situation, if you were going to look here, we have a
de
public health
Latinoamérica que atienden
system
el 80% de la
that actually
población,
services
es
around
decir, alrededor
80%
de
of the
15
population.
millones
That is,
de
means about
habitantes, 16
some
millones
15 million,
a lo largo
16
de todo el
million
país.
people
Es un
throughout the
sistema
nation, and it is a
público,
system,
¿no es
a
cierto?, que
public
data
healthcare
del año
system that is dated
1952
since
y que
1952,
fortaleció desde
and
los
it's
años
strengthened since
60, incluso
the
antes de los
beginning of the
80, el
60s,
desarrollo de una
so
atención
that they can
primaria
have the
que
development
se
of primary
extendiera a lo
care
largo de
that would
todo
be
el país.
understood
Entonces,
throughout the
esto
country.
es
So
un
it is
precedente
important
sobre el
that
que
because
nosotros vamos
it
a
is a
elaborar
track
para
record from
poder
which we can
desarrollar.
incorporate from that health
Ustedes
component.
pueden ver esta red,
And
es
here
una
you
red
can
de
see this is a
hospitales
network.
que
It's
cubre un
globalized,
territorio
it's actually
determinado.
public, it's
En
throughout
Chile,
a
nuestras
specific
grandes
territory
regiones
in Chile.
sanitarias,
Our great health regions
o zonas sanitarias,
are
les llamamos servicios de
the
salud.
goals we call health
Esto no es injusto que
services.
se confunda eso
It's
con
not a good
servicios
name
directos,
because
porque son
sometimes it's
sectores
actually confused with the
llamativos
direct
dentro
service out
de
there,
los
but they're
servicios de
actually
salud.
called
Y
in
eso
the
implica
territories
tener
is called health services, and that is the territory
hacia
that
la
you see
izquierda
here.
ustedes van a ver los
To the left, you're going to
los
see the centers
dispositivos que
that have
corresponden
the
a atención
different
primaria,
devices that
los
actually are
centros de
part
salud
of
familiares,
the
CEFAM,
primary health care.
los
The
centros
CEFAM, which is the
hospitalarios,
family
¿no es cierto? Y los centros que
centers,
tienen el conjunto
they're
de
the ones that have the set
servicios
of
un poco más
complex
chiquititos
care, a
en
bit
ciertos territorios
smaller
para poder
in
lograr
certain territories to be able to
esos
have good
objetivos.
access that we have with the
En algunos
executifs.
lugares
And
hay
some places we have
hospitales
what we
comunitarios
have community
que son lugares
hospitals, because that's historically
son lugares que
we had
permiten
hospitals in those
formar
places, and in time
centros de
they
atención
became
primaria y pisos
in
funcionales
primary healthcare centers, and they have also services of
comunitarios generalmente en
hospitalization,
zonas
and
rurales
that's why we
más
call them
aisladas,
community health.
¿no?
The
Y
rural
tenemos los
areas,
servicios de
isolated ones,
emergencia
and then
en
we
la
have the
parte de abajo y
ER
postas
in the
rurales, esas
bottom
son las
side,
3S o
and
puntos de
the
salud
B,
rural. Y abajo
the
SAPU, SAR y SUS, que
post-rural
son
areas, and
los
we have the
servicios de
SASU.
emergencia
They
integrados
actually
en la
talks
atención
about
primaria,
emergency
que
ones
atienden en general
inside the primary health care that
o
actually
en franja
service
horaria
or in a
hasta la
certain
medianoche o bien
hour set,
de todas las noches
sometimes at night
independientemente de la
or
zona.
sometimes all throughout the
Este es
night.
el primer nivel de
And this is
atención,
kind of the
un lugar
first
por donde
level
entran
of care
el tema de
through
atención de
which
salud
people come in
y
through the
cuando
health,
existe algún
come
problema
into the
de
health
salud mental o
system, and when they
respiratoria
have
es
a
derivado
problem of
hacia
mental
un
health, it is
centro
derived
retirado.
to the levels
Luego,
of
una
greater
secundaria
complexity, a
sería la
primary level, a
la atención
secondary level,
ambulatoria,
which is
y
one
después
to
la
have an
terciaria que
ambulatory
sería
one, and then the
la
tertiary level where you have
hospitalización en centros de salud
hospitalization.
mentales.
In the case of mental
Estos
health,
centros de atención primaria
these
se conectan
centers of primary healthcare are
principalmente
connected
con
mainly with what
centros de
we
salud
call
mental
the
comunitarios,
centers of mental
se llaman
community health,
COSAM o CESAM,
CESECOMSAM or
en
CESAM,
Chile.
which are
Y
the
se han ido
acronyms
desarrollando
for
frente
Chile,
a
and they have been developed
centros
them
de
with
salud
time, these
especializados
centers
en
of
personas que
special
tienen
care
problemas con
for
consumo
these
de
areas that
sustancias
have
y centros
drug abuse
que necesitan lo
problems
mismo
or the centers of containment, which we have the very few that we have throughout the country. Those centers of community health center that are similar to what they have in Peru that you saw in the prior presentations are the axes of work because these are centers that are at the community in direct coordination with the primary healthcare centers, and they have a very close ties with those people because we have a model that is of consulting services with mental community health, and then they meet them with the primary healthcare, and in particular the ones that actually they work in mental health in the primary health care, and they perform supervision, analysis of cases, and eventually they guarantee the continuity of care they derive from there to that very same group of professionals in mental health, so that in a general way there is a link in community care, what we call the continuity of care. In the case of need, we can go to the other level of hospitalization, be that in general hospitals. In Chile, we have 4 psychiatric hospitals that have been in a process of greater disinstitutionalization on us, but our central axis of mental health is primary care. And then at this level, specialized with centers at the communities, and then they're territorialized. They actually take care of geographic area as if it were a distribution. But how did we manage to get this? And this is what the primary care. And basically, we actually have to find ourselves in 990 when Chile actually came back to the democracy. We finished the military dictatorship and we returned to democracy. They did not have any type of development at that time. And then we have those first 5, 6 years of experiences that were useful to define what we were going to do later. And towards the year 2000, we have the first programs in primary care, in 2001 to be accurate, in primary care. And then we had like a Trojan horse because for the onset of what this component was going to be in primary care. Then after that, we had set a policy that is more generalized in the country, which is a policy of rights in health, which is called GES, which is general rights in health. And among those problems, one of the first, because that was in a progressive way throughout the country, and the next years in 2005, the first problem was the first episode of schizophrenia, and the one in 2006 was depression. But it is done on the grounds of everything that was developed before in terms of primary healthcare intervention. I'm going to show it more in detail. And after that, in primary healthcare, we begin to install more and more specific programs that I'm going to mention more in my presentation, which begins to just basically broaden about the problems in mental health and at the same time making it more complex in terms of improving the quality of the mental health care in primary care and always tied to a network. And finally, the challenges, because in spite of the important developments that we have done in Chile, we still have a whole set of challenges. And the 2 guest speakers after me are going to focus on that in terms of innovative experiences in these terms. So, what was 1919 in Chile? What was the snapshot? Basically, what it calls of the same models that I showed you before, but here we had at the primary healthcare level, which I want to concentrate, we had centers of primary care. We called them peripheric clinics. Practically, there were no programs of mental health. So it was a pilot program in terms of alcohol abuse that was dated from the 1970s and is specifically installed in the southern side of Santiago that had recovered very much by 1984, 85. But I would say that it's all the only thing that existed, and then the only experiences that we had with the HES, there were none there. And then we had installed a center of adolescents, those teenagers that actually were there to tackle the substance abuse, and that was starting around 1985. But that was the only thing that was there. And in close care, we had psychiatric hospitals in several parts of the country and psychiatric services in some general hospitals. So in reality, we had like a disconnect between the system, and it was very, very difficult. And specialized care was difficult to have access to it, and there was a great bottleneck, to call it like that, to be able to get to the specialized care. Basically, in the decade of the 90s, we did some pilot programs, and I had to carry them out precisely what was the development model of the south of Santiago, the capital of Chile. And there, that initiative was the model for what was then the development in the rest of the country, what was called in the area of demonstration, because it was like the model, the demonstration model, to actually see the development of what was going to be there so that we can have mm, directors that can stay there and to understand how it could be done and to be able to tweak it and perfect it to take it to the rest of the country. What did we do? We created programs of mental health with logic with the existing problem. This was a very important step because the idea is to actually follow the logic of public health that we had with the health programs for the child, for the mother, for the adults, to be consistent to the way we tackled other health problems at that time. It was a way to come into the same logic of the health system of the country at the time. I think that that was a very important issue. I find it like that because a psychiatric is a normal specialty, and the psychiatric hospital were something that was on the outside of the cities. It was not something like something foreign to the health system. So here, the idea was actually this: when we have a logic that they already have the health services, building these networks, and then that's the way we transform these adolescent centers in what they started, in what was going to be the mental health ones that they had, and they would have specialized resources, and they had them there in the community. And then we had the ones to lead in each territory. In the case, we set up a team that actually carried out the entire process. And at that time, I don't remember. I think that there were three centers of primary care, and then we had like 5 or 6 centers for adolescents. But it was a team that led all of this, so that it was very important in each territory. And then we built this realistic proposal. And it was this through a very participative process of primary care, using the diagnosis of the problems that they had established, of the exported ones that they actually defined, like 3 specific programs. And then they have of alcoholism, and then they had the emotional ones, and then they started with the ones that we have this depression and intra-family violence that had not been sensitized. So then they started for that. They called them programs, and then we had assistential processes that started with the detection of these primary health care. And these processes actually can actually be specialized, but there were components and there was resolution in the primary health care level, and then some criteria for intervention to specialized institutions. And that is what I pointed out here, to define priority problems and to build assistential processes that we can monitor and tweak. And in synthesis, oh, everything is actually written here. I have the references. And this was around 1991, 1992. And basically, it says that there are 3 lessons learned here. One, the integration of the mental health component within the logic of social security services. And this is very important that what we're talking about here, because that was a very important point, because it was something sensitive for everyone. This and enabled us to bring the patient in there, the adult, as we have there, a program for women, a program for children, etc. Leadership, that was very important, decentralized with coordination at the national level in the ministry, but there were decentralized leadership with specific goals and specific tasks, and then using participative processes with realism and with assessment. Next, the country is beginning to develop plans, and then the first plans around the year 1995, and then the one 2001. And then we had like a critical moment because that plan marked what the developments we have up until today, and there was a new version of that plan in 2017 that now proposes a modernization of certain things that were necessary to modernize. But I would say that the 2001 plan, that was the plan that actually set the roadmap that was important, and there you design what was going to be the network as we conceive it today. And in 2001, because of a whole series of things that I will tell you, there we install a program for a integral care at the primary level. It was a commission by the president at the time. She, at that time, it was Michelle Bachelet who actually gave us that mandate and almost like, yes, excuse me, I'm sorry, she was the Ministry of Health, I beg your pardon. And it was her initiative as a Ministry of Health. We sort of kick off this, which was a program of clinical practice that we built with many other participation. We had specifically there, and we had there with the resources that we had in primary health care and adding their other resources. We hired psychologists in primary health care, and on the second level, we provided medication for in the intervention. With that, and with this assistential process that the guideline meant, we were able to assess the program. And that is exactly what we did in the year 2002 with the pilot program. And this was very important because that evaluation, after showing that it was effective as of the follow-up, we also showed that it was a very low cost. It was a low care, the monthly cost of this package of services that was useful so that the Ministry of Finance, the ones that actually sets the budget 3 years later, decides to broaden on this program to all primary healthcare posts for the next year. So at the end, we extended it throughout Chile. Okay. After that, we passed on to be a HES problem. It was actually to guarantee certain health services, but the grounds for that was this program of depression. Here, we can see the amount of people with diagnosis of being depression. It was zero in the year 2000. It actually went to have like new services around 150,000 people, and then they stabilize and it actually drops a bit because there was a sort of backlog of demand that was there, but then it was settled in the year 2006. We incorporated of the basic rights in the HES system, and there you can see how it implied that the percentage of the amount of visits per person in primary healthcare grew very much, and at the specialized level was maintained because in the bottom there you have the resolution of the primary care in respect of the programs as depression. So unequivocally, this was a pioneer program that is actually kept today as a GES problem, as a basic right problem. Now, that first experience, we assessed it jointly with two colleagues, and we did an evaluation of the implementation process, and based on the interviews and the analysis in depth, the key decision makers in policy, the ministers and the like, and the different programs who defined it, then we saw fundamentally what were the critical factors to be able to upscale this and launch it throughout the country. And there were four factors. First is scientific evidence of two types to have had like the magnitude of the problem. And for that, we contribute the valency and the illness burden. The other ones, the study of assessment was showing that it was important and it was good for the people and their family as well. And also the costs were low. Second, the second important factor was leadership that the team had at the Ministry of Health. We had Dr. Alberto Minoletti, that I think you actually met him, and with the leadership of Alberto and entire team that they have with him, they were able also to push and promote the component of mental health and care. then some strategic alliances, basically with other ministry of the Environment of Finance and the ministry that actually had to deal with poverty at the time. And third, the institutionalized process that has to do with what I mentioned before when I was saying that we're speaking the same language. Here we did the same thing. We had this program of uh, integral depression care, and it was incorporated in the entire development of the entire health system. And even in terms of finances, they were also part of that system as part of the program with the financing insured for the part of mental health. And those were the four factors. Of course, I have broadened in far more detail in my publication. You have all that in detail. I'm not going to spend the time now. Further on, we began to grow it. As you can see it here, you don't have all the detail, but we we upscale the coverage so that we have more prevalence. We had like substance abuse, family violence, intrafamily violence, and then the coordination was key with justice, with police, and with national services of family care or the respective ministry. And in time, what we end up doing is that all these different programs are integrated in one program that is integral care of mental health in the primary healthcare system, and that's around 2009. And then we change it from a system of financial budgets by programs instead of designating as historically specified to a different type of budgeting that is around 2015, which is the incorporation of per capita, which was the way in which monies were transferred financially to the primary care. And I would like to say that that's a fundamental step in the changes of the resources towards this primary care in the components of that one. And that is how we built this network in primary health care. And it is tied now, as I described at the beginning, with the community mental health services. What are the main challenges that we have in facing the future? First, we have to have this care model that is predominantly biomedical towards a integral care. We need to have and this is a challenge. This is not only for mental health, but actually more of a model that actually works about on specific problems, to one that actually a model that is actually more multiple mobility. We pass from a model that is centered on caring acute health to a model that is actually in accompanying people, avoiding care for illnesses that evolve into chronic diseases and so on. So we come from the more generals where mental health should be part of that. A second challenge that we have shown many a times in respect of pandemic, it actually became very important where the countries in our region, in particular in Latin America, practically have done very little development, which is the mental health of the workers of as healthcare providers. It's in the healthcare provision, their mental health. I think that we have 11 countries in Latin America that during the pandemic, we have showed how the levels of stress and potential cases of mental health problems among these healthcare workers. At the same time, we don't have any policies previously oriented toward these type of workers, and we didn't make any active measures to care for the mental health of those healthcare providers. And this was an issue that came out, and I think it's going to stay with us and fundamental is to draw attention up without the need to repair of the mental health of our workers. And there are more challenges, but I want to mention the few ones so that the next guest speakers are going to dedicate time to that. Specifically, this one, Jaime is going to tell us about this experience, which has been his own development, has been very valuable as how to introduce the component of stigma in the healthcare, because we know that the stigma is the main factor that conditions the disability and sometimes the access and to the treatment of all these people that have a mental health problem, including the very workers that we have there. So with the first. We should actually lead with this statement. So a second aspect that I think it's important, I would say that is it has a cost there because we have a task is to worry not only about the mental health care, but actually to see how do we promote a better mental health, and that requires a work with the community and other institutions that we have here. One of the big issues is going to be to sort of generate literacy in mental health so that the community begins to care about the mental health of all of its members. And in that sense, the educational institutions, education, the institutions have to be a very important sector where we have to work so much so that we can promote mental health and to identify the problem and to actually intervene as quick as possible. There we have two experiences. I am very grateful for all the time that you have given me. And with this, I would like to close with a very important message. And we said, there is no health without mental health. And I leave you here with a beautiful picture of Valparaiso from one of its mountain slopes. And I hope that we can have later a more interesting discussion. Thank you very much.
Muchísimas gracias, doctor Rubén.
Thank you very much, Ruben.
Súper interesante la
Super interesting
presentación
your
y los
presentation and
desafíos que presentaste.
the challenges
Parecen
that you presented at the end. I think that they're critical,
particular en ese momento.
in particular at this time when we are actually are coming out, God willing, from the pandemic. Yes, we're. I'm not so sure we're out, but we're on our way out. Yes, definitely.
Sí, los desafíos
Right. So these challenges for the mental teams are enormous. The issue of their own mental health of all healthcare providers
y el estigma
and
que
the stigma,
ellos
yes,
mismos
that many a times really presents huge barriers in respect of the persons that need the care. So thank you very much, Dr. Alvarado.
Yo quería
I
recordarles
would like to remind you, please, to all guest speakers and members here to please send your questions through the chat. There we have the options of questions and answers, and we do have a question there. And at the end of the presentation, we're going to open up so we can discuss before we get to the panel members' answers. So once again, Dr. Ruben, I would like to invite now Fanny Leighton Alvarez. She's a medical doctor, a psychiatrist, and she has a PhD in psychotherapy. And she works in the juvenile unit of the psychiatric hospital Salvador in Valparaiso. She's also a teacher in the medical faculty of Valparaiso University in psychiatry, in juvenile psychiatry. So Dr. Fanny is going to make a presentation in respect of mental health in youth, how to tie education and health, the contributions of that research and the work in the network. So Dr. Fanny, thank you very much, very welcome. And 15, 20 minutes for your presentation, please, if you may. Perfectly. Thank you very much, Roberto. Thank you very much for all of you and the opportunity to share all of our work. I'm going to share my presentation here. Here it is. Right, as Roberto said, the presentation that I am about to do is to basically to tell you about two experiences in which I have participated in respect of one of the challenges that Ruben has actually proposed as to how can we tie and optimize the communication between the educational establishment in health and how can we improve the mental health at schools or educational institutions. So the first program that I'm going to tell you about is an intervention that we manage within a research project that was carried out. And I had it there as the main researcher with Dr. Ruben Alvarado that you already know. And this program had as a main goal the development and the assessment of the preliminary effectiveness of intervention model based on information technologies and communication technologies to diminish the suicide risk among adolescents in Chile. This project was denominated later as a CLAN project, or what's the CLAN project, because it's still underway. What we want to answer to in the CLAN project is a concern in public health in Chile and in the world, which is the increase of suicide in the infant, adolescent, or teenage years. This increase in the race in this area should be an alarm signal. We have communicated strategies and made proposals to mitigate this alarming situation in public health. And one of the things that our government did was specifically to generate a guideline of recommendations to prevent suicide at educational institutions. The idea had like six goals or six main pillars, and one of them, the least developed, is the incorporation of preventive programs at the educational establishments themselves. This project, this CLAN project, is precisely that, is a preventive program that was developed, executed in the educational establishments. This, well, one of the factors that we believe that one of the key success factors of this CLAN project is that from the beginning, jointly with the research team that carried out the project, we added a group of experts, experts by experiences, which were seven teenagers that participated in the design of the intervention. These seven teenagers had diverse characteristics in as far as age, where they lived, their socioeconomic levels, and they also were representative of sexual diversities, and they made work groups to see the content, to see the design, and to see what type of technology they were going to use. And from the meetings of these experts, they took out certain conclusions very important when they developed this program. First, is that it had to do a program that was not based in the pathological, in the illness that we could all be exposed to, and that all the educational community could be exposed to a health problem, and they had to be based, therefore, in promoting the well being. Another important thing for adolescents was that to participate in an anonymous way to be able to reduce the taboos at the time when they express certain concerns or topics to be dealt with. Also, the content had to be relevant. So for teenagers and with a language set that would be adequate for what they use, the same language. So the visual concept was actually very important so that these platforms actually become attractive. And also an important thing to make them attractive is that it was developed in in a realm of gamers, so they can create an avatar, they can make some points, and therefore they were self-explanatory, so that they could include them in forums, that there be a neutrality in gender, and that they also deliver. And this was something that was very important, to deliver information as to how to be able to help a friend, how to make it effective, the support among peers. This, for example, this was the visual concept that we generated. Now we no longer have it an app, and now it's a web platform to be in an app, an app. And here you can see we can actually personify it, etc. Then this was carried out in the preliminary stage, in the pilot stage, at three educational institutions. And then we have from seventh grade to ninth, seven, eight, nine, and up to junior year. And then we had 100 and 428 participating members, and they were at six courses, and it was within the app and outside the app, promoting that where so that they can have social contact, they can have social emotional development, and leading these course so they can have the application, and it was to be done within the curriculum of the students, and an hour that we call here of the council hours with the professors here. And then we actually assess the process so much of implementation and effectiveness that we had there. And we saw them there with interviews in depth. And then we had the focal groups in the directive ones, teachers, students, that they all participated, and the team that actually developed it, and it included a group of experts. And in respect of that one, we saw that it was very important that it was for everything, for the entire educational community, not only so that the entire educational community can participate, not only students, but also professors and the teacher assistants, so that the application be actually very usable, that it was intuitive, and that they would be able to navigate through the application without having to have uh, a prior instruction. And the most important results, or the main result, was to diminish the risk of suicide. We saw that the intervention group, after 1 month, had a reduction in 10% in suicide there, while the control group only had a 5%. And this difference in the intervention group was statistically significant. But not only that, aside from that, the intervention group showed an improvement in their self-esteem, in their social support, and a reduction of emotional spaces like anguish or depressive symptoms. And as I was telling you, this has been upscaling, and today we have developed the application in an environment that is a virtual environment that we have for mobile applications. So this is the first project that I wanted to tell you about, and it was very well received by the schools, by the educational institutions. One of the things that actually is a spin-off of the development of this clan project, actually, but the name of the project started in the meetings with the expert group clan as a community, and we are a clan with a common goal, and it was the need to connect best or better with local players of the mental health services in the event that a teenager boy or girl would need to be sent to a program, health program. And here I want to tell you of another experience. It doesn't come from research, it comes from the regular practice of mental health in respect of how we actually can have a different sense, a different organization to the work in to the network. And this project is called the Eco Barrio and Solidarity for that one, and it was implemented on the first time in 2015 and 2018 at three sectors in Valparaiso. But today we are actually implementing once again in another sector, in the MENA sector associated to a program of literacy in schools. The team of social workers of the hospital from the secondary levels. I work in a psychiatric hospital that actually works, that has hospitalization, but it also has the center of specialized care. So from the juvenile child unit, Carolina Gomoloy leads that, within the framework of her master's or master's studies of community services, data diagnosis of the different members of our child mental health. And actually, they mention all the different difficulties, for example, in education. They said that they had difficulties in health and access to care. And the primary care says that they needed to tackle the care of these users that were more ecologically the teams of Sinam, or the ones that are the protection for infants. that were under the government's care, and there were different languages, and that therefore the communication made it difficult. And we at the community level, we had a more integral care that we needed to preserve it the most possible in the community of the user, and that they are actually supported in early queries, because we saw that some serious problems of mental health were being derived to specialized care at a late stage. So this all spoke that there was no true articulation in the intersectorial network. And what could we have done in that respect? So we thought and incorporated, as we mentioned, this ecological model. How could we do or contribute in the development of this ecological model where you have the microsystem, the child, and other different systems? And what we needed is to be able to generate were the ties, the links, the spaces of interaction among the different microsystems. And there, with the schools, with the CESFAM, and with the secondary level, and there also with the family tribunals. So for this, the idea that we had was to occupy a space that already existed, that we called it here from the year 97, more or less. We celebrated meetings that we call the Mixed Commission of Health and Education, which are meetings that are currently done monthly in every territory. And these meetings, they have a representative basically of the primary healthcare system and the educational establishment, and they're actually to have an agreement on practical topics, for example, the calendars of vaccination, because here the primary health care actually goes to the schools to proceed to give vaccines in oral vaccination and etc. So what we proposed was that okay, to in a sort of on and off virtually as we call those meetings, and to mix it at 1 month instead of making this with the COMSE, we're going to do it about the Eco Barrio or Eco Borough. And from there, at those meetings in Eco Borough, we actually brought in this to all relevant players locally that actually had to do with the network of mental health and local impact, including the programs of SENAM and other relevant actors. And we began to do some work with different strategies to begin to generate a common sense to co-build what was the goal of the network, what were the purposes, the vision, the critical nodes, and the improvement opportunities. So we defined the common objectives, which was to strengthen the intersectorial ties between health, CENAME, that was called education and community organization, to promote environments that facilitate the well-being and the mental health of children, boys, girls, and youngsters that I mentioned in the territory. And we did different activities, fairs of mental health, training sessions for the members of the network open to the community, and also training to the mental health monitors in the establishment and the education. And there we have a great part of the team. And the one in red is Carolina Godoy that actually pushed this initiative. Another of the things that we have in these systematic meetings and this work in the ties here towards the need to make a network of networks, to have a coordinator for each team with the territorial APS team, who a coordinator for the schools, SENAM of education, and the community organizations. And we work from the hospitals as the organizers of this network of networks. And what were the results that we saw throughout the time? Well, that we were able to make objective. One of the most relevant is that we generated, and this by the idea of the very participants of this network, is to formulate or to create a form, a single form of a school and health. That single or sole form that had the legal authorization and the consent of the parent to share information between school and health, which at the end of the day is a more effective derivation, a better follow up, but actually a continuity of care of the cases to actually come here necessarily in the process and to be able to share information. Aside from that, there was a reduction of serious mental health that actually went to there from 12 years before that, and actually we lowered it to 8 years. So we actually intervened much earlier so that we could be remitted to the hospital. Of all the members of the network, they saw positive the participation of this echo borough and then this sense of belonging and group cohesion. A WhatsApp group, we created a web page where we geo-referenced the different players, the schools, the Sename, the community organizations. And lastly, there was a collaborative education system, and that had to do with training everyone, yes, but also to generate common languages, common denominators in this endeavors. They actually had free training and certified in this case by the hospital, Red Salvador. And then we had training to students and to leaders in mental health. As I was telling you, post pandemic, we retook the idea of implementing once again the Eco Barrio, and we're doing so through a project financed by a researcher in health. And to this, we added, and perhaps it was latent here, additionally, an intervention in literacy on mental health for education institutions. Those were the two experiences that I wanted to share. And here we were in one of those training sessions that we did at the schools, even to the Carabinier, as you can see there in uniform, they participated in that training. So I think that I hope that you have understood the message that we wanted to convey. And I am now open to your questions. Thank you very much.
Muchas gracias, doctora Leighton.
Thank you, Dr.
Muy
Layton.
interesante y me
Very,
parece que
very
están
interesting,
aprendiendo
super
muy
interesting,
rápido
super fascinating
los
to involve
jóvenes en todo ese proceso.
youngsters in this entire process, to
Muy,
involve
muy interesante,
teenagers
muy bonita experiencia
and
realmente.
children is very, very interesting experience,
Los
really,
resultados
and
y
with
son
results that are also
impresionantes,
impressive,
realmente muy exitosos.
truly very successful.
Muchísimas gracias.
Thank you.
Am,
Thank you very much.
Pasamos ahora
Now
al
we will
doctor Jaime
proceed
Zapat.
with Dr. Jaime
Doctor
Zapat,
Zapat
and
Muñoz
Dr. Jaime Zapat Muñoz de la
profesor
Peña
asociado
is an
del
associate
Departamento de Salud
professor
Pública
of the
y
public
Salud
health
Mental
system
de la
and
Facultad de Medicina
family medicine of the medical
de la
faculty
Universidad Católica de Chile.
of the Catholic
Es
University
director
in
del
Chile,
Magíster en
Universidad
Salud
Católica de Chile.
Pública
And
de la
he's a
Universidad
magister in
Católica
public health from the
y
Catholic University,
profesor
an
asociado
associate
de la Escuela de
professor
Salud
of
Pública de la
the
Universidad
School of
de
Public Health
Santiago
of the University of
y es
Toronto.
único afiliado
And he
del
is an
Centro para la
affiliated scientist for
Evaluación
the
y
Center for
Salud Mental
Addiction and Mental Health
en Ontario,
in
Canadá.
Ontario, Canada.
El doctor Zapat nos va a hacer
Dr.
una
Sapat
presentación
is going to make a
basada en el
presentation
tema de
in
estigma
respect of the stigma,
y se intitula
and
Reducción del
it is
estigma
called
hacia las
reducing
personas con
stigma
problemas de salud
of
mental debido a
among
su
people with mental health
participación
problems
en la atención
and
primaria.
or uh,
Jaime,
substance abuse in primary
muchísimas
health
gracias
care.
por su
Jaime,
participación
welcome. Thank you very much for your
y
time, for your presentation, and
les recuerdo
your
pues por
20-minute
favor
starts. I would like to
sus
remind you,
preguntas
please, to
y
send your
comentarios
questions,
por
your
escrito
comments
en el chat.
in writing to the chat.
Jaime,
Thank you very much. Jaime,
Muchas
please, all
gracias.
you. Well,
Buenos
thank you very
días.
much. Good day.
Agradezco a los demás
I am
panelistas,
much
a
obliged
Rubén, Fanny,
for my
también
former
por invitarnos
speakers
y a la
who are
organización del
commenting
Banco Mundial por habernos invitado a
in
este
this and for the
webinar y
World
por
Bank. They
supuesto
actually
invitarnos
having me
también
invited me to the
es un
webinar and
tema
to the
que es
public.
importante
It is a
precisamente
very important
cómo
issue to
fortalecer
think
la atención
how to
primaria
strengthen
en un
the
sistema de
primary
salud
care
con un enfoque
in the
comunitario
health system with
y
a
cómo en
community
particular
focus
eso
and
de
how in
Chile
particular the
encuentra,
Chilean experience
encuentra desafíos
sheds light
adelante.
and
Así
finds
que
the way to
sus
go forward. And
experiencias
we're going to
científicas
speak
e investigación
about the
aplicadas
specific
sobre la
experience
reducción
of
del estigma hacia personas con problemas de
applied
salud
research
mental
in terms of stigma on mental health and or substance abuse in primary care, which presents a essential challenge. As you probably all know, uh, healthcare doesn't start at the establishment, but it really starts in the very self-care and the opportunities of support that there exist. And at some point in time, in the middle, you have the primary healthcare as an essential source of contribution to that mental health in connection with the network. And that's why in the last years we speak of ever more the importance of integrating mental health to primary care. And that is happening in the different countries, not only in Latin America, it's not the exception in respect it's been actually been working as Ruben and Fanny have all mentioned in this integration. However, this integration also has to face the problem of stigma. I am a family doctor originally and working in primary care. One sees that it's not only the need that is present, but it's also the challenge to actually have to uh, tackle our own very stigmas without knowing that affects the care and actually makes it difficult the access and the quality of care for those people who need mental health care or have a problem of substance abuse. Stigma, as you well know, it's a word that is used for many years. The Greeks used to use it to indicate that there were certain people that had an unusual condition that was bad from the moral perspective, and it was considered a person that was tainted and we should keep away. More recently, some definitions they have there that they mention them as a social process that there is when the one who's labeled has a stereotype is segregated and loses the status and it gets discriminated and it is produced in situations where there is a power difference that enables that segregation. Another one definition is actually the personal experience that a person suffers in the rejection that they suffer associated with the stigma. And behind all of this, there's a theoretical framework where we could see here that population and groups of them that have different conditions, like in this case, to present a condition of mental health, they can eventually be stigmatized as of their ignorance there. So this is a process of stigmatization that leads to stereotypes that generates prejudices and eventually that actually means the conduct in the different environment. And this can happen in what we call the public stigma, and this is also generated like other types of stigmas that I'm not going to present in this occasion, but it is always important to present the self stigma that one may have. All of this means, in the end, an impact on human resources in health, well being, and social inequity, especially in respect of those people who have a mental health problem and self stigma. This also happens in a social and cultural political environment, as happens in every place in the world, that facilitates or makes it more difficult that that stigma works there, where the communication media have a very important role to play. And here, this mediation between the general population and the group that is stigmatized, we have the primary healthcare intervention teams with a role there. And it's very important to remember that the stigma is not just by a specific condition, but actually it occurs at the same time in a person, given the presence of several conditions, as we're going to see further on. Now, this stigma, of course, is going to make more difficult the presence in those people that have a mental health problem and the social services that may be provided in the primary care. That stigma is right in the middle and it confronts, it hinders that relationship and it makes that the quality and the adherence of that care actually diminishes. Thus, we have this great challenge that is broadly founded on evidence. There's ample evidence. And we had here the possibility as a team to review what was happening in Latin America. And then we found health teams that have the possibility of being part of the problem and to contribute to stigmatization, or as we have seen many a times, to be agents of destigmatization and inclusion. They can be both. The stigma, as we mentioned, it's not only because of the mental health condition, but also it occurs at the same time considering your ethnicity, your nationality, your gender, your social status, your the existence of HIV, AIDS, all of these sets that somehow it begins to singularize on a human being as an experience and stigmatize. But in primary care, naturally, we found ourselves with people that present multiple conditions that potentially are stigmatized, and therefore it is a very sensitive space of opportunity to offer a better care. And that is how I want to speak in a very briefly way, a very long story that started many years ago when I had the possibility to begin to work in Canada in the Center of Mental Health in Ontario, the APS in Ontario, and we were having some training processes for Latin America mainly, but also for people of Ontario. And then we detected that there was a barrier that it was known from there, but when we work with the primary healthcare system, it came out as a main difficulty, which was precisely stigmatization. And that's how we started to work with the primary healthcare centers in three in Ontario. And then we had later to develop a project with a greater scale, with greater financing to be able to show what was the level of effectiveness in the intervention. And then in Peru, we also had a very beautiful challenge with Dr. Bustamante with the support of Canada, where we actually tweaked this intervention to reduce stigma. And then the focus has been in Chile first to be able to understand what was the stigma status in respect of mental health among professionals of primary health care. And now, in the last years, working directly next to Ruben and other researchers with the team to progress in the stigma, specifically in primary care, that it was randomized and controlled. Within all of this, one would ask, yes, the stigma, yes, it may be a problem. We know perhaps we had not thought that primary care also can actually be a critical aspect. And once we begin to see that it is a problem of public health, that is very important, that the very condition of the person, and then we have how do we measure this stigma? Because we know that we have to ask, we need to measure so that we can act, and we know what is the impact of that intervention, and that is for the validation of instruments. And we are actually working on that for a long time with different colleagues. And recently, we were able to publish this cross-cultural adaptation of four instruments to measure stigma towards people with mental illness and substance use problems among primary care professionals in Canada and in Chile. This is the examining of the application of the opening that helps us to measure the opening mind survey and so on, and what happens with the stigma. And what I don't want to bore you with so many results of our first study in primary care in Chile that was with more than 800 professionals of health and more than 500 users of the primary healthcare in Chile, but just a tiny sample to see how, by using a scale of social distance and schizophrenia, and in this case, in the case of coca, cocaine paste, we can see this the scores here. We have an average; they're actually higher in respect of addiction to cocaine paste than schizophrenia, that is 24 to 20. There is stigma, and this is a scale that we use that somehow we would know as a proxy just how willing are we are to come people who have different conditions of living with that, to have this condition, to be a neighbor, to work with someone like that. And well, in the end, since this is something that is actually very simple, we actually can do them there, and it enables us to understand better what is the reality of the stigma. But we could not understand it well if we didn't incorporate qualitative data to see in depth the problem. Just as an example, on the left, what users had that actually had a focus groups and interview in the different parts of Chile in the primary care.
Profesionales, personal sanitario
And
que
then we
también
have the sanitary personnel that actually can share there in their
vean
focus
desde el
groups.
caso de
And
ustedes,
here we can
¿cómo
see the
se
user
lleva a
case.
cabo
Of
la
course,
observación
yes,
de
if you have a
cada
problem,
uno?
it's because you have a trauma.
Nunca me mira a los ojos.
They never look at me in the
Urgente
eyes,
sanitario.
referring to the
Entonces,
senator,
no,
the senator,
hay
but
pocos
they never
psicólogos,
have times, and there
otros
too many
usuarios
people and very few
psicológicos
psychologists and other users says
recomendarían
when I do a
cancelar o
show,
volver a cita.
they change the
Y
appointment.
por otra parte, los profesionales
And then the health
los
professionals,
pacientes de
when
salud
we this
mental
patient,
son muy
mental health
complejos.
patients
Los de
are
salud
complex
mental me
patients.
cambian.
The mental health
Se
there,
podrá decir
they're
que
actually
poco,
overburdened. I don't
poca
like
adherencia o a
they
veces
have little
pequeños
adherence. So
tratamientos
whenever they feel
que
well,
ayudan a
they
aliviar
stop
la
the
ansiedad.
treatment.
Por eso
But they
existen
know that it's a
procedimientos
game. That's why they're
preventivos
aggressive.
de
That's why
mejora
they're
del
aggressive.
funcionamiento
So
de la
this
salud
is an array
mental.
of
En esta relación,
interpretation in
usuario
both sides,
o paciente
from the user standpoint and from the
también
professional standpoint.
tendríamos que
That
decirlo,
also there we have to
muchas
say
citas
we have a
positivas
lot of
y
positive
modelos de personas que están
medical
trabajando con un
appointments
perspectivo
and so on that
preventiva.
they're actually
Son,
working on a
son ejemplos
perspective of recuperation that are examples
entendiendo
for
los
their
temas de alto
practice
problema
and
médico
understanding that we have a
en la
very
atención
important
primaria del
problem
sistema de
in
salud
primary health care
pública, que es
and
el
in the
tipo
health system.
la
The
pregunta muy
stigma,
grande
well,
después de
natural
avanzar en la
question
prevención,
after
¿cuál es
having
la
progressed
delimitada
in the
entender mejor
research to
cómo
delimit and
estamos
understand better is
manteniendo
how
los
can we
conocidos
progress to
estigmas?
prevent
En
reduction,
ese
to
sentido,
prevent this
hemos
stigma.
trabajado
And in
hace varios
that
años
sense, we have
con
worked for
diferentes
several
instituciones
years now, an
originalmente en
intervention that was
Costa
designed
Rica,
initially in Canada
luego
and
en
Ontario,
Chile,
and then
pronto en
it
Perú,
was adapted to
y
Peru.
actualmente con los datos de
And
Chile,
currently, with
desde el
Chile
estudio
and
que nos
data,
permitía entender que
the
los
study that
dispositivos de
enables
estímulo en
us to
atención
understand
primaria
that
se
the
adaptaban
stigma in
a los
primary
procesos
care was
clínicos
actually
y
adapted.
hoy
We
estamos
review
ya
a pilot,
en
and
el
now
proceso
we are
para
in a
finalmente medir
process
el
to
impacto que puede
measure
aportar y
the
medir
impact,
la efectividad de esta
to
intervención en este estudio
measure the
de
effectiveness in this
resultados
study
controlados.
that is
Y
randomized and
estamos
controlled.
dejando
And here
huellas
I've actually
también
tried
en
to
el
leave
resumen
some
de lo que se ha ido
footprints of
haciendo.
the
Y
different
también estamos
publications that we have there. And here we have here as a
realizar
sample,
este estudio
without entering into detail in this
randomizado,
study,
contando
we
con
have
datos
this
científicos,
randomized
demostrativos,
control one that is a very beautiful collaborative one with Peru and
Canadá,
also with
incluso
the
el doctor
people of Canada even,
Corrigan, que es muy
and Dr.
reconocido
Corrigan, which is a renowned
estudioso del estigma
uh,
y también reconocido en
authority
este
and
campo, nos ayuda desde
academic
Estados
on
Unidos. ¿Dónde
stigmatization.
está este proyecto?
So,
Voy
where
a
is this
cerrar.
project today? To
Efectivamente,
close my
hemos
presentation
hablado de
well,
los
effectively,
enfoques para
we
tratar
have
los temas.
shown here
Teníamos que poner
that
mucha
for
atención a
stigma,
los
we have to
objetivos
put a lot of
porque no es lo
attention
mismo hacer
to
un
cultural
proyecto que se
aspects. It's not
hacía
the same
en
thing to do an
Canadá, en Perú,
initiative
en
in
Chile,
Canada,
en una
Peru, and
zona
Chile,
urbana, una zona
or
rural,
in this urban
trabajando con
area,
elementos
rural
muy
area to
diferentes.
work with them.
Importante y
It's different,
fundamental
and
a la
therefore it
hora
is
de
fundamental
la
to
escoger
work
de instrumentos y en qué
in
intervenciones
instrument
sean apropiadas para los pacientes.
intervention instruments that be
Estamos ahora
appropriate
instalando
to the context. We're upscaling this
ya
pilot,
hemos terminado el
upscaling.
proceso de
We have
reclutamiento
actually
y casi estamos
finished
a punto de
the
finalizar el
drafting of
liderazgo
human resource, and we've actually
que viene
finished
hacia adelante
the
por 18
baseline that
meses
actually is going to
trabajando
be
en la
implemented for
motivación con
18
nuestro
months. We're going
equipo,
to work on
pero
motivation
en ese
and
proceso
commitment. But
aparece ni más ni menos que
there we
COVID-19.
have that process,
En este
and
estudio
COVID comes out in
esencialmente
a project that
especializado en
essentially
áreas
was a
terreno
phase in the
de
terrain,
salud
face to person.
pública
So
y se
all
desarrolla entonces
of a
en ese
sudden now we have to
contexto
open
que permite
these
a los
alternatives, a
centros
web
participantes
intervention to have
responder
participating
encuestas, nos
tests,
permite
to
también
answer surveys.
subir
It enables us
manejar
to
las
upload
capacitaciones
the
como un elemento
material for the training
complementario
as a
a la
complementary
actividad
element
presencial.
to
Entonces, hoy
the
tenemos una
to the
intervención que se
face-to-face
puede
intervention. Now we
entregar
have
de
an
manera
intervention that we
presencial,
can actually have
de manera
face-to-face.
online, pero
We could have
también
it
de
online, but
manera
also we can have it
mixta o
in a
híbrida.
mixed
Si
or
ustedes
hybrid.
están aquí abajo en la foto,
So
estuvimos
here
con
we have at the bottom
nosotros
here is that this effort is not
haciendo
only in
acompañamiento
Chile, but it's actually a work
de
with
Canadá y de otros
colleagues
países de
in
América
Canada
Latina
and
y
other
constituimos
countries in Latin
un
America.
consorcio
And we
de
were able to constitute a
personas de
consortium
distintos
where
países
we
como
participate
Bolivia,
in the different
Perú,
countries like
Brasil,
Bolivia,
entre otros.
Peru,
Y
Brazil,
bueno,
among
estos
others. And
tiempos de
then
pandemia ha
in
estado
the
un
last
poquito
years, due to pandemic,
tenso este
we have
consorcio,
been
pero
at
estamos listos
rest
para avanzar
and we're
en
ready
una
to progress
implementación más
in
fuerte, en estigma, en el futuro.
more research
Y este
based
es
on
un
stigma. And now
ejemplo
I'd like
de
to
trabajo
show you
en línea para que se
this end
imaginen.
result online so that you can
Desarrollamos
have a
un equipo
snapshot in one
para
of
los
the introductory
capacitados
videos for this
ya a
training
los equipos de salud
that actually
para
is
reducir el
geared
estigma.
for the
Y estos son
health
los elementos
care
clave
providers
de la
to
intervención.
reduce stigma. And this is what they have in their intervention. Hi, welcome to the session about STIG, mental health, and substance abuse. of problematic consumption. So now we'll want to tell you what are the objectives of this session to understand the phenomena of stigma and their different definitions, to learn about the mechanisms of stigma and what it does in the mental health care and the problematic consumption of alcohol and other substances, and to go more in depth about the complexity of the diagnosis, to explore the impact of the different forms of stigmas of people, to people who live with mental health problems and problem with substance abuse, and to understand the role of the professional of those primary healthcare professionals, and also to know the anti-stigma actions within the primary healthcare system. And in this training, the members will be able to broaden the comprehension of the stigma phenomena and their expression towards mental health and the problematic consumption within the context of primary care, analyzing the negative impact of stigma in context of recuperation of those people, and to ponder in respect of proper practices that promote stigma, and to have the necessary changes to tackle a perspective that's anti-stigma. If you're ready for the session, let's start with the session.
Eso es parte de los
That
niveles
is part of the levels that we have been creating to have this support in the distance, and to remind you that the intervention is destined to the organization of the primary healthcare center that actually includes an educational component based on contact. It means that people that have challenges in mental health
en una situación de estabilidad y son
in a
buenos
situation of stability and are good
contribuyen
facilitators contribute also in these trainings. They have a component there of communications to make it sensitive for the primary healthcare system. We have a component that is called or champions or leaders, where 3, 5 people of the health team and community leaders assume a protagonist role so that they can lead this intervention multi-component process at their primary healthcare system. And there's a last component, the fifth of this intervention, which refers to the analysis of policies and procedures at the primary healthcare place, where they deliver concrete recommendations after analyzing them so that the centers improve, for example, their processes of incorporating new personnel, the work that they have to do in crisis situations, and what they have to do. Now we have this intervention that has been polished for
y
several years now,
a la
and
realidad
adapting them
local,
to the
nacional,
realities with
con una buena
the
recepción
local
de los
data, with a good
ordinarios
reception
y
of the
hoy
primary
en
healthcare
proceso de
systems, and today
implementación
in the main
hemos
process of
visto
implementation, how we have
niveles
seen
de
the
extendiendo todas
possibilities
las
of continue
facetas
to
que se vayan
extend
requiriendo
with all
para
the ones that
distintos
we end
tipos
up
de
having to the
pacientes.
different contexts.
Para
And
trabajar
that
la
is that
realidad
for
local
us
y
to have
global,
mental health
tenemos
care
que hacerlo
in
con
primary
nuestros
health care, we
pacientes.
have to
El
do
desafío
face
principal
this
y hoy
challenge
tenemos la
of
posibilidad
reducing
y
stigma,
oportunidad
and
de
we
hacerlo
have a
con
few
mucho
opportunities to
gusto.
actually do that. Thank you
Quisiera
very much.
agradecer también
I
al
also want
personal,
to thank,
todo el
before
equipo,
closing,
a
to the
los
entire
equipos de
team,
atención primaria que han participado en
the
el
primary
estudio,
healthcare people that have worked in this study, as well as the local
internacionales que han sido parte
contributors and
de estos
international
socios.
contributors that have all been part of that shared effort. I want to say thank you to all of them.
Muchísimas gracias, Jaime.
Thank you, Jaime.
Muy interesante.
Very interesting, this topic.
Es un desafío importante, ¿no? Es uno de los
It's been an important challenge
de las dificultades de acceso
of the
servicios
access difficulties
de atención a la salud mental.
in
Muchísimas gracias por la presentación.
healthcare on mental health issues. So thank you very much. Before we proceed
A los comentaristas, a los
to the
comentarios,
guest speakers and comments,
yo quería
I wanted to
y agradecer a los
take
comentarios
advantage and to
por
thank the guest speakers
mantenerse a los tiempos.
for respecting their times. That enables us to have time.
Mirar algunas, tenemos una
Go and
pregunta
see here. We have a couple of questions here in the chat,
y creo que fue
and I think that it was addressed to Ruben,
presentación.
who did his presentation.
No, la pregunta de Hilaria dice,
The question says,
es impresionante ver
it's impressive to
a
see
lo largo del tiempo el crecimiento
over time the increased number of patients receiving mental health services in primary care settings. How were the budgets adjusted for this? How are MH services funded?
¿Cómo se ajustaron los presupuestos para ese crecimiento de la demanda? ¿Y cómo son los servicios cómo son financiados los servicios de salud, de atención mental en la atención primaria? Sí.
Correcto. Mira, lo que yo comenté
What I
nació
commented
como un
started
piloto,
as a pilot
después
program
se instaló en 15
that
centros
first was actually set up in
hay que considerar
15
que
centers
en esa época
nationally.
había 400.
At the time, we had like some
Primer
400,
desarrollo piloto.
and these were the
Se
first
hizo un
pilot programs. And then we did some special financing that enabled one to hire psychologists that before they didn't have them as professionals at the primary healthcare centers, and the purchase of antidepressive medication that before they were not included in the healthcare insurance program. So we designated budgets in each center of primary healthcare when that project was installed. It was not really one of the ones that they had before. Nobody, so it was a budget designation that was additional. So when we started to grow throughout the country, we followed that same strategy. We designated a yearly budget that was associated with this line. But what I pointed out is that by 2015, we actually passed to the more general system when we had the primary healthcare system that now budget is per capita in that territory, and that's how they budgeted. And then they designate this amount of funds. So the entire cost associated to mental health care now was incorporated in that per capita budget item. So that is now like that since 2015. And this is the way in which we finance the project. I think that that was clear. Yes, 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 yes. It was perfectly clear. I'd like to take advantage of what are the guarantees that define in proper health care. Yes, perfect. The entire set of guarantees. A guarantee of access, it means that it must be attended, that once you do the diagnosis in so much time. A guarantee of quality that actually helps to work, and then a financial guarantee. So how much money could you pay as a maximum to one person? This in the public system doesn't matter very much, the last guarantee, because in general, the public health system covers all or almost all the expenses. But in the private system, in private insurance, it does have an importance. It's actually generated an uproar, the private insurance company in 2005 when this was launched, because the program of care, they made the biggest uproar because they said it was a tremendous expense, but actually these were the guarantees. But for example, if the problem is an impact to the heart, the accessibility that must be cared for, or metabolism in the next 10 minutes for heart disease with depression, you establish that it should be seen at the first time within the next month, for example, or the following month, or something like that. So that's how they establish them, the quality systems. Okay. Thank you very much. Ruben, now we have other questions. Mariela asks, how are you constituted the health teams in the different programs, for example, the CLAN program and the Eco Barrio program? How are they constituted, the health teams? Right, now my mic is working. In Eco Barrio, we have represented there all the teams. What we did to implement the ECO is that we had a management team which organized the Eco Barrio meetings, and that management team was organized by a social worker that had half-day shift for the 3 territories, an occupational therapist that had tested, I don't know, of 1/4 or a half of work, and a psychiatrist had a half work share. That was the basic team of Eco Barrio. And what we did was to organize the meetings for the three teams to do the follow-up, plan the activities, and to do the setups. And from there, the participants of the network were all the players locally. But yes, that is a very good question, because although this Ecobarrio program did not have a lot of extra resources, what we did have initially is that the chief of the mental health unit was working as a psychiatric specialized service. He had the vision and understood to make this program that had to do with coordination with social networks and a promotion or timely access to mental health services. It was fundamental for our programs at the hospital, and he transmitted jointly with the director of the hospital that we could have them in networks so that they can have the resources, the three professionals, social worker, occupational therapist, and a psychiatrist, right? In respect of the team of the CLAN project, I don't know if there Ruben wants to comment. Who else was in the team? But we had the developers of the application that included the information systems, the group of experts, which are youngsters, and it also includes psychologists, Ruben, who's here, and then we had in the execution, we have the people of the educational community. The one is taken by the professor, the peaceful coexistence at school team, and then they have the course of the web platform. I don't know if with that you want to add something else to that. Yes, perhaps it's very concrete, not to take up too much time on this. The application or the app is available for professor, and it's not the people of health, but actually it's for the professor who uses this as part of a teaching activity
Salud mental.
to make mental health promotion. And they play in class and they give you homework. They use the same app in that sense. It has videos, games, quizzes, and so on. And then it actually has a forum. They have a counselor. It's a cat. It's like a Muppet cat, but behind the cat is what you have is a psychologist who has that role within that system and belongs to what is the peaceful coexistence team at school. And that they also have a school psychologist that has that within the system, which is what they assume that role. And it works that way. Thank you. Thank you very much. In follow-up, there is a question. Going back to Ruben, the pilot program incorporates psychologists since when? Are the psychologists as part of the same program? Yes, of course. We incorporated the psychologists since 2001, and we preserve them to date. In the year 2000, basically, there were no psychologists at primary healthcare systems. From 2001, and in the measure as we broadened the program throughout the country, it made them so that we can have psychologists at all primary healthcare posts in the country. And then we have their more specific, and then we have the training, I would say, but they incorporate very much of the information that they bring it from their formation from the outside. So now they're permanent, they're part throughout the country, and they were incorporated to the per capita income, and they're part of the structure of the financial budgeting scheme in mental health. Thank you very much, Ruben. We have a question that came through YouTube for Jamie. And the question is really very interesting. Can you have access to that training in Colombia, for example?
Sí, bueno,
Yes, in general, the idea is to be able to progress so that the learnings that we actually had in our countries, Peru, Chile, or in Canada, that they be
puede ir también diseminando hacia otros contextos con todas las adaptaciones.
disseminated to all the institutions that actually are willing to have the
Podemos ir
needed for our meals. We can share some of our materials with the meals and the training as such. It's still in the process of implementation in Chile to see if it's effectiveness, but there are elements that we already know that are relatively clear. So, for example, education based on contact, and then we have ideas on that. So these are parts of this expertise that we have on the team. And you have to share as to how to do them and how they have done them with act as a mediator in workshops where users participate and professionals participate, and those learnings can also be shared, understood that each one of them, there has to be a process of adaptation. What is interesting in the intervention is that it has this organizational focus. It's not the classical workshop of training for the personnel, 2, 3 sessions, and that's it, you finish, but rather it's a process that is more continuous, more hands-on, and thinking that the organization must change as its personnel changes in terms of progressing a more inclusive conduct along that line. So it is, of course, willing to be shared with the entire team. I know that people in Canada want to have that exchange in that sense. We would need to contact it. Still in the platform, we have materials that is incipient, a very short brief, like the one I showed you. But there are the places where there's sessions where we need facilitators, and so some of those elements, those can also be shared already. Thank you very much, Jaime. So now we have another question by Monica. Perhaps for time reasons, we are going to go to the guest speakers and we'll come back to Monica's question later. So we're not very tight on this. So now, without further ado, we now have two international commentators who are not Chilean, let's just say, and we'll start with Dr. Megan Kinland. She's a scientist in the project of the Margaret Sellers Wallace Center for mental health for juveniles and family, and the Center for the Detection of Mental Health in Toronto, Canada. The presentation of Dr. Megan is going to be in English, and as you well know, we have access to simultaneous translation services if you so prefer. If you wish to connect at the icon at the bottom there where you have the little globe. So Dr. Megan.
Thank you very much for your presentation and participation.
Hi, everyone. Thank you so much. I'd like to thank Jaime and the World Bank team for inviting me to participate in this very important webinar. I'd also like to thank the panelists for wonderful, fantastic presentations and learning about Chile's experience with mental health services and primary healthcare. So I want to share a bit about the experiences from the McCain Center for Child, Youth, and Family Mental Health at the Center for Addiction and Mental Health in Toronto. My comments are going to focus on integrated youth services, touching on aspects of primary healthcare, youth engagement and stigma, and building on Fanny's presentation on the Echo Barrio. So in terms of in Canada and internationally, there's been a growing consensus/interest in integrated youth services, youth-friendly services that are community-based, that provide holistic care, that include primary health care, mental health services, and substance use services, education, employment, and social services. And really, they're referred to as one-stop shops. And the idea here is that we're focusing on early intervention because research has shown that by 25 years of age, 62.5% of mental health disorders have appeared. So it's really a window of opportunity, adolescence and young adulthood, to intervene and prevent mental health disorders or reduce mental health disorders. Also, the integrated youth services have been developed in order to overcome barriers in terms of access, barriers to mental health services, fragmentation of services between primary health care and mental health services, a lack of developmentally appropriate services for youth, long wait lists, and not the services not really responding and tailored to the needs of youth and families. So within Ontario, Canada, I'm going to focus on two integrated services, although across Canada, there is a network of integrated youth services. So within Ontario, we have the Youth Wellness Hubs Ontario, and this co-locates in one location primary care, mental health and addiction services, employment, education, community and recreational services. And the aim is to provide walk-in services. It's rapid access to mental health and other services. It's tailored to respond to the needs of youth and families. And it also reduces the transition between these services and referrals onto other services, which research has shown that a lot of the times the youth fall between the cracks with other services. And so currently we have 14 YHU hubs in Ontario and 8 in development, and really they're community-based services for youth and families. At the same time, we have the Youth Can Impact trial, which is the first randomized control trial looking at how well these integrated youth services compare to treatment as usual with hospitals. And those findings are forthcoming. And then at the core of these services, and as something that Benny and Ruben talked about, is youth engagement and co-production of services. So research has shown that youth engagement enhances equitable, informed, contextually relevant, and responsive services to the needs of youth and families. And within YHU services and Youth Can, we have engaged youth in terms of the model and service development, in terms of governance, training and evaluation, communications, knowledge translation. We also are working on tackling stigma, although I think it would be great to chat with Jaime about this further, because I think the work that you're doing is fantastic. And in terms of the work that YHU is doing to tackle stigma is focusing on really promoting skills and well-being activities within these community-based services, so that when youth come to participate in these activities, they can then learn about the health services that are being promoted within the YHU services. As well, based on the recommendation from the WHO, we use non-pathologizing and non-medical language to tackle stigma. Something that we're working on right now is defining and measuring quality and outcomes. So in a recent systematic review, we found that quality in adolescent mental health services is not well defined. There's no standardized definition, and it's not, there's no standard measurement of that. And so the Institutes of Medicine and the WHO define quality as the degree to which services increase the likelihood of desired health outcomes. And it often is referred to, there's a slew, there's a list, but it's often referred to as accessible, acceptable, equitable, appropriate, efficient, effective, safe, timely, integrated, and people-centered care. So within quality has been shown to be important for youth and adolescents because it promotes seeking, receiving, and continuing care. And the government of Canada and integrated youth services within Canada are really focusing on standards of quality. So this includes integrated service delivery, measurement-based care, youth friendliness, and youth engagement, among other standards. So for example, with youth friendliness, the McCain Center is developing a youth friendliness assessment scale, which is at the core, youth friendliness is at the core of quality in youth services. And we're developing this instrument that we will then implement within YHU's services to determine how youth friendly they are. And we're also open to collaborating with other countries, with organizations in other countries to adapt the tool and to assess youth friendliness in other settings. At the same time, we've also been focusing on virtual services. The pandemic sort of ushered that in. And what I will say about virtual services is that it's cost effective. Youth are more likely to take up the use of technology. But I think that there needs to be further research on privacy, confidentiality, safety. Also being able to build a bond between the service provider and the youth virtually is an issue, as well as providing culturally competent care. So in conclusion, I just want to highlight some areas of opportunity in Chile. Based upon what Fanny was chatting about, it seems like there is a focus on youth, and I understand that based upon the IHME estimates that 18.4% of 10 to 24-year-olds in Chile have a mental health disorder, which is similar to Canada. Also, something that we're doing in Canada with youth services is focusing on equitable, culturally competent care. And my understanding is that within Chile, there's opportunities with immigrants and also indigenous populations in southern Chile, as well as rural populations and lower socioeconomic strata to enhance mental health services there. So I guess to wrap up, one of the questions that I have for the panelists is, how do we use social media to promote mental health? This isn't something that's going away, and it's probably going to only get bigger. But I say this because I don't know how I feel about social media. After having read the book Stolen Focus, I can see the negative aspects of social media, but I look to you to answer that question. Thank you.
Thank you very much, Megan. Ahora yo paso la palabra al doctor Humberto.
I'd like to hand over now the floor to Dr. Humberto, who is going to make his comments. And Dr. Humberto is a medical psychiatrist. He's director of the Research Center and Development of Mental Health of the Peruvian University Caetano. And Humberto is now in Spain currently. So thank you very much, Humberto, for your time and your participation, and welcome. Thank you, Roberto, and to congratulate Ruben, Jaime, Megan, and Fanny for all those interesting presentations, also the comments of Megan. And As of this, I would like to say that perhaps after having participated in these three meetings, it is all too clear that we are facing a challenge, a very similar challenge in Colombia, Peru, and Chile, and we are somehow trying to insert mental health care in primary health care. And this challenge evidently is a very large challenge. We are achieving such apparently with plenty of success, but also with a lot of tasks to come, many challenges to face. And a bit I wanted to comment about that and about the contributions that the guest speakers have done. The point where I believe things vary is actually the strategies that we are implementing in one place or another. But I would like to say that it has to do a lot with the context in which we're trying to implement these changes. Of the Ruben's presentation, it is all too clear for us that the health system in Peru is different from the Chilean health system and it's different from the Colombian system. And these differences are important as long as in Chile we have a single financing fund and a more integrated system, as Ruben was telling us since 1952, the model of public health is actually being articulated ever more while for us the system is clearly um, open public health there, but then we have a social security system that is separated, and as a matter of fact, a private system that is beginning to have a very important push in the past few years. So the changes that one may do generally do not go to the entire territorial realm. In the health authority, which is highly fragmented, we don't have regional government that have a relative autonomy. And this does not allow for a public policy on mental health. However, and here is where I want to frame ever more this difference so that it helps us see the possibility that one or the other strategy can actually give, or at the end of the day, that it had to come out this way in trying to find solution if we were to look, as Ruben was commenting, the point of the iceberg was their integrated depression program, because it was one that actually came to the primary healthcare system and it came in there and starting with a very similar logic to the other public mental health programs. So we tried to actually come there to the primary healthcare system from different ways. It was an important project, was the Polima project, where we tried to accompany a region altogether. And then what we saw is that they require a continuous, persistent accompaniment. And it was 3 years in one region, 3 years in another, and so on. And like that, it was practically too intense, the issue of doing so, and with a great difficulty to upscale. So for us, it resulted that like the centers of community mental health that grew quite quickly. And I think that that's where the difference for Chile, what Ruben was commenting, because the community health center is actually to appear as support to primary health care. For us, a bit it was the mental health community. There's should be the one that actually promotes the primary health care, but actually that makes it like fragmented or different in each one of these stages. In some experiences that we had, a great difficulty to place the mental health care in the primary healthcare system. And here we have a bit of to the work that Jaime did, which I think it is a very important work because it actually has this category of stigma. It actually goes there to the stigma as a like, kind of anti-coagulant between mental health and primary health care. And on that, it seems to me that although the term stigma actually does account for many things, I also think that it is necessary to have a compenetration with other elements, to groove with other elements that we see in this process. When we speak of stigma, we put the emphasis on this subject, but as a matter of fact, it is present, yes, but also it is the very much the very object, the purpose, the nature of the practice of care, of healthcare. So let's just say that in the healthcare, generally speaking, are venues to speak of the body, but they're not venues to speak of the mind, of the psyche. So, of course, what was shown by Jaime, it is that in these terms, in these phrases where he plays very successfully in what users said and what professionals said, denote that incompatibility. So apparently there would be more things also, and I think that that is a point that Ruben also takes it of the challenges. So it seems to me that the point is there that with which we agree is to what degree do health services generally would be able to absorb all this demand of mental health care, as long as under the concept of mental health, which is a concept that has been evolving and growing acceleratedly. At some point in time, we thought that mental health basically as it was the story of this mental health, and the mental health was basically focused on psychosis and severe disorders. But then we have this great explosion of problems of expansion, let's just say, where we have more this issue of depression, anguish, with this great burden of morbidity that the entire public health system is actually now surprised by that. So now this is a huge burden. To what degree with a health host can actually absorb it. So here perhaps when we speak of tuberculosis as HIV, we're talking about figures that actually are told in the thousands. But when we speak of mental health and depressions, anguish, and deaths, is counted in millions. And this actually, we speak here of these huge gaps. The 13% actually have access to this health services for mental health. If all of these would have that, it would overwhelm any mental system, even more than when we begin to see through the pandemic, yeah, that the pandemic really, this great increase of the suffering of people. But it's a suffering that is clearly is a social suffering, and an economic suffering, yes, but we have that instance, that realm of public policy on health policy that actually turns any suffering in a sort of mental pain and everything that a society cannot contain and keep, and then it's actually displaced towards the realm of health. So here we also have of an over demand, and this place within the health system for a system that is overwhelmed. Furthermore, and that in this point it becomes in a very critical issue, given that the fact that in the pandemic also showed that the health services, or at least in Peru, had to be almost like in 100% to caring for COVID and didn't have time for anything else. And actually, it limited to the other problems and the other mental health problems, and not necessarily of the specialized level to the primary care, but actually outside of the system. So mental health was pushed out of the system and pushed out of the public system. For example, for us in some surveys, in the middle of the survey, it says that 40% of the people that had a mental health service had it in the private system. So the pandemic like kind of pushed to the public health service, to the private service, and outside of the system. So there, somehow we need to reconstitute a system of care, of mental health care, understood as a psychosocial problem, with a health system that doesn't have the category or the resources to understand the problems of mental health, and that they have been placed a bit there. So there is where I find it that is very interesting of what Fanny actually proposed on this topic of thinking this mental health problem is actually focused there of the clinical one that have to take care of the mental health, but rather to pass on to this care by having experts by experience, not a program that I think that is about the most interesting, not because precisely there we have the issue in dominating the community, not the pathology, but actually focused on the suffering that you have out in the community, expressed with their own codes, with their own languages, and management that geared by people who have lived the problem somehow. And then I think that this focus of community health per se, understood more in that logic, that community would have to take care of the community and in the logic of care, more of attention, but actually as an alternative that is very strong. And perhaps that also binds us or joins us together as an ideal, bonded by an ideal, to be able to truly pass to a community care. And this probably implies a rethinking of the very services and the very health systems. And as a matter of fact, with the great difficulties that work can have, because of course, integrating other knowledge bases in validating these systems is not easy. We're talking about a relationship that is not only a knowledge relationship, but a power relationship. We are speaking of a proposal in which we must admit other ways of thinking, of comprehending health. So very probably this actually for other health problems to have another reading more in the logic of care than in the logic of providing medical attention. So I think that the works that have actually been presented from my perspective, not only that they are excellent in academic terms, but actually that they go in a direction that is political, cultural, and I think it is a way that somehow that we have a mental health with community focus, we are moving there. However, we are trying to find ways out, but I think that that leads us to continue to integrate, to continue to work jointly, collaborating, and in that sense, this effort of the World Bank to tell us, to invite us to think on this topic. I think that is excellent. And I am very rich. Right. That's what I had to comment. Thank you very much.
Muchísimas gracias, Humberto.
Thank you very much, Humberto.
Estamos llegando a la hora.
We are basically on time,
Muy
but perhaps
rápidamente,
very, very
quisiera,
quickly.
Poner la pregunta que quedamos en Mónica.
I would like to pose Monica's question to Jaime.
La pudiéramos contestar rápidamente.
If we could answer that quickly, please.
La pregunta de Mónica dice,
The question by Monica is the study and observation and the possible resolution of stigma.
¿cómo surgió
How
y si ha sido efectivo?
did it come out, and did you actually solve the stigma problem?
Bueno, le conté cómo había surgido en este
I
trabajo
told you
inicialmente
how it had worked initially with Canada with primary care, where we visualized that we had that stigma barrier, and as of there, we began to work as a team in the study. And we did an international seminar, a small one there, and we concluded that effectively it was a problem, and we needed to investigate there because it was very little what we did there, specifically in primary care. And in reality, what we have seen there, it's promising. It's difficult to make the assessment because whenever you do a study without controls, and whenever we can do it with control groups, there is a whole implementation challenges that doesn't make it all that simple. So then we have to see that effectiveness. We have to wait a bit to know. In the case of Peru, the trend was actually favorable, and in the case of Canada also. But it's important to say that there were certain variations there of 5 or 10% in the stigma level, that it seems little, but if you actually take it to multiply by the amount of population, it becomes a significant number, and we have to have continuity so that at the end of the day, they all have a greater impact. That is quite promising, but these are figures that are of that magnitude, and to understand in social culture that good as it may be, the intervention in 1 year or two is actually very difficult to have such a category change, but it goes in that direction. And in general, it should be able to have that one with economic one, a high one there, and the and one there to have the quality and the access. It could be very, very powerful.
Muchísimas gracias, Jaime. Sí,
Thank you
la
very
verdad,
much, Jaime, and that we have here to do all these changes, cultural ones and preconception that we all have. They're difficult changes, really, that they require, they generate a resource. So I think that we're actually getting to the conclusion of our meeting. And on this meeting, I don't know if the guest speaker want to do or make an observation, and then we have the Megan comments of Humberto.
Les dejo, sí, rápidamente, pero si no, cerraríamos la sesión.
If not, we'll close the session.
Quizás Megan nos hizo una pregunta.
Megan posed a question that is very is how to use the social media and the social networks to do that. I really don't have a response. And then I have there's that our youngsters, they actually use their social media too much. One of the things that was, and then we have in this project, the youngsters that actually have used for more than 2 hours in social network for 2 hours, they have a greater suicide risk than the ones that actually use it the less. So perhaps it's very complex to use it, and then for something that we can do, for something it's actually that produces a negative effect. I don't have an answer, but Megan, I don't. But I just want to draw the attention that the people who do use it are more prone to it. So how to use that tool there? That's the best I can do. Thank you, Ruben. And then we have here that we actually can define the cause-effect relationship. I don't know. It could be that actually the people that actually use the social networks actually do it by reasons of feeling isolated or I don't know. Obviously, I mean, Yes, but I don't know. We don't know actually when you have to cross the border and so on. It doesn't enable me to have them there. We're actually following a bit of group of 600 youngsters as a good sample. So we're going to do it funny. We're going to do the analysis in certain months. So we're going to see if we actually obtain one of those results, and we're going to have them and so on. But it's a great topic. Yes. We'll be back, and then we'll invite you again to have you there so that we can have the presentations and so on of the results. Right, thank you very much to all guest speakers, to all commentators. It was a very good session, and we'll be closing very well this cycle and of webinars in mental health. I'd like to thank the ones that we have in the 3 days, and obviously to all participants of today. But we are perhaps closing with the words that Mariela puts in the chat. It's actually, we have to think and rethink of that new panorama of mental health. And I think that is actually a very good closing words, Mariela. I'd like to remind you that the sessions, as well as they're all recorded, and they would be available in the webpage of Salud Derecho. We invite you to actually register there, which is at www.saludderecho.net with only one D. Right, thank you very much, and God willing, we can see you soon.
Muchas gracias.
Gracias, Roberto. Saludos a todos. Roberto, que estés bien.
Gracias, felicitaciones, buen trabajo.
Igual, un gusto verte.
Igualmente.
Bien. Lo mismo. Chao, Jaime. Te veo a lo lejos.
Gracias, Rubén. Gracias, Humberto.
Nos vemos, Jaime. Igual. Chao. Nos vemos.